Okay, welcome to our clinical pathological conference organized by the Department of Ophthalmology. Today, our main presenter, Dr. Wai, is actually an ophthalmology master student. I'm the co-chairperson. I'm Dr. Niki, an oculoplastics fellow that is under HCTM. And Dr. Othmaliza is our head of department. She's also an oculoplastic surgeon in the Department of Ophthalmology, UKM. We also have with us Dr. Leong who's a consultant radiologist from the Department of Radiology, as well as Dr. Mahrunissa binti Mahadi, who's an endocrine fellow in HCTM, Department of Medicine, UKM. Okay, so can I just have a show of hands? Who here are master students? Okay, so the group in front are master students. Okay, how about medical students? Okay, how about those at the back? Are you all medical students too? No. Y'all are, sorry? Sorry? Nursing, okay, nursing. So we have nursing joining us today as well. And of course, some of our consultants, specialists from other departments as well. So a very big welcome to all of you and thank you for joining us today. Without further ado, I think I would like to invite Dr. Wai to start with the case presentation.
Hello. Good morning, everyone. Good morning, dear panelists, Dr. Niki, Dr. Othmaliza, Dr. Leong, Dr. Mahrunissa, and also fellow profs, lecturers, specialists, medical officers, and also medical students. Today, we'll be presenting about a topic on bulging tubes and disrupted gazes, a closer look at the thyroid eye disease. The patient is Mr. A, a 46-year-old gentleman who has underlying diabetes mellitus type 2, presented with binocular diplopia, left eye ptosis, left eye squint, and also bilateral eye redness for the past 6 months. From the history of presented illness, the patient initially presented with diplopia, double vision, for the past 6 months. He described it as binocular, whereby closing one eye, the double vision will disappear. It is gradually on onset, and it was intermittent initially and became persistent after that. So for the image, he described it as vertically and horizontally displaced, whereby the first image is higher and the second image is lower in a diagonal fashion. And the double vision is present in all directions of gazes, which was more noticeable when he was driving and denied any complaints of blurring of vision. He also complained of left eye proptosis, the protrusion of the eyeball, which was gradual in onset, and he felt like the left eye was bulging outwards and noticed by his wife and he himself when he was looking into the mirror. He denied any eye pain, any dry eye sensation, or difficulty in closing his eyes. He also complained of a left eye squint with a restricted extraocular muscle movement for the past 6 months, which was gradual as well. Together with the protrusion of the eyeball, the eye was noted to be deviated infranasally, and he was not able to move in certain direction of gaze. There was slight pain upon upgaze, but no pain at rest. He also has a bilateral eye redness for the past 6 months, whereby he denied any eye discharge, any use of contact lens or eye medications as well. Other relevant history, he denied any history of which points towards thyroid disorders such as palpitations, tremors, heat intolerance, sweaty palms, increased appetite or loss of weight, or diarrhea or neck swelling. He only described himself as an easily anxious character. Other relevant negatives include patient did not have any ptosis, drooping eyelids, no facial asymmetry or speech disturbances. He denied any symptoms of raised intracranial pressure or spatial compound lesion or stroke, such as headache, nausea, vomiting, or neurological deficits. He denied any ENT symptoms and denied any infective symptoms and no TB contact history or high-risk behavior. He has known to be a poorly controlled diabetes for the past 1 year with a HbA1c of 10% on oral anti-diabetic agents. No past surgical history. Bilateral eyes known to be high myope with -7 to -8 diopters on spectacles. No allergic history. His father passed away due to gastric carcinoma, while he does not have any family history of thyroid disorder or autoimmune diseases. He works as an insurance agent, non-smoker, non-alcoholic, and is married with 5 children. Upon physical examination, the patient was alert, Diseas was full, BP was normal, 130/75, heart rate 79, beats per minute, regular rhythm, SpO2 100% with no tachypnea. Random blood sugar was 9.7 millimoles per liter. So on ophthalm examination, we noticed that by the eye optic nerve function tests were normal. His visual acuity with corrected glasses was able to achieve 6.6 and 6, which was perfect vision. Relative afferent pupillary defect test was negative. Light brightness and red saturation was 100% with normal color vision using Ishihara, and confrontational tests did not show any restricted visual fields or increased blind spots. So this is the primary gaze view of the patient. On general inspection, we can notice that the patient presented with bilateral upper lid swelling and also mild redness of the conjunctiva. And the left eye also presented with eyelid erythema as well, which was not very obvious, but it's over here. But the patient did not have any chemosis, which means that the conjunctiva is not swollen, and there's no inflammation of the caruncle as well over here. From the Hirschberg reflex, when you shine a pen torch from the patient's primary gaze, you see. Okay, so from the Hirschberg reflex, the right eye Hirschberg reflex was central. The left eye showed a non-axial proptosis with inferior nasal displacement and esotropia of about 15 to 30 degrees. Using a Hertz exothermometer, we noticed that the patient has a difference of 3 millimeters, showing left eye proptosis of 21 millimeters. So other positive thyroid eye signs include Vigorok sign, whereby there were upper lid fullness, Kucher sign, showing a staring and also a frightened appearance of the eyes, the Rumpel sign, showing upper lid retraction, which was about 2.5 millimeters away from the limbus, Von Graffi sign, with a retarded descent of upper lid upon down gaze, and also a jerky movement, which is a Boston sign upon down gaze of the upper lid. So this is a 9-gaze photo taken using a 9-gaze app. Okay, so how do we interpret this? For this patient, the right eye has no restriction of movement. For the left eye, we start with the primary gaze first. Okay, so with the primary gaze, we notice that the eye is inferior nasally deviated with esotropia. Okay, so then you start to think, is this cranial palsy or something else? So we think about cranial tree. Okay, if cranial tree oculomotor nerve is affected, typically it will present with upper lid ptosis, okay, with a downward and outward displacement of the eyeball. And also it will affect the superior rectus, medial rectus, inferior rectus, and also inferior oblique. But from this photo, it shows that the left eye elevation function is affected. Otherwise, then we think about, is it a cranial 4? Superior oblique muscle, is it affected or not? So superior oblique will function is intorsion, depression, and also abduction. The abduction looks a little bit affected, but the intorsion and depression seems intact. Okay, if the cranial 4 is affected, typically it will show an X-cyclotorsion instead. Okay, then we think about cranial 6, abducens nerve. Is it affected? Oh, okay, so there's a limitation of the lateral rectus during abduction. But however, this patient presents with a complex ophthalmoplegia, whereby the elevation and also the abductions are predominantly affected and do not point towards a single nerve palsy. And the patient also complained of minimal pain upon up gaze. The patient also complained of binocular diplopia in primary gaze and also all gazes. So other examination, upon eye closure, there's no lack of thalamus, mildly injected conjunctiva, but otherwise the anterior segments are generally normal with normal IOP. This is the fundus view of the patient. By the eye, fundus are tessellated with myopic optic disc slightly tilted with peripapillary atrophy. Otherwise, the CDR is 0.4, normal. The clear disc margins, normal macular fovea reflex. Retina was flat with normal vessel calibers. And no signs of diabetic retinopathy, despite HbA1c is 10%. Otherwise, other systemic physical examination, the patient seems to be clinically euthyroid with no signs of hyperthyroidism or having thyroid storm, no goiter. Cardiovascular system and respiratory system was normal. No signs of macro or microvascular abnormalities of the skin. CNS, there's no optic neuropathy. Other cranialism seems to be intact. And the upper and lower lids tone, power, and reflexes are normal with downgoing Babinski and no cerebellar signs. So how do we classify this case? Is it mild, moderate to severe, or sight-threatening? So for our patient, he seems to be under the category of moderate to severe grace of orbitopathy. Why? Because the patient seems to have a lid retraction more than 2 millimeters mercury, 2 millimeters, exophthalmos of 3 or more above the normal for race and gender, and also inconstant or constant diplopia, double vision. And he does not seem to show any signs of sight threatening, which is very severe. And these patients with this thyroid optic neuropathy tend to have positive RAPD and also optic nerve function tests. Our patient seems to be normal. So then after that, we assess, is this patient in active phase or inactive phase of the thyroid eye disease? So we can use this CAS score, clinical activity score, to score the patient by adding up 1 point for each finding. For our patient, he presented with pain upon outward gaze, swelling of the eyelid, redness of the eyelid, and also conjunctival injection. So his CAS score is 4 out of 7, whereby CAS less than 3 is inactive, grace of orbitopathy. CAS 3 and above, the patient seems to be inactive. And for a CAS score more than 4, it shows a positive predictive value of 80% with a negative predictive value of 64%. Upon follow-up, let's say, during clinic follow-up subsequently in 1 to 3 months' time, we can add on all these findings with an increase in measured proptosis more than 2 millimeters, decrease in eye movement with a limit of more than 8 degrees, and also decrease in visual acuity, 2 Snellen chart lines over 1 to 3 months. And all of this make it into how much out of 10? So our provisional diagnosis was moderate to severe and active grace orbitopathy or thyroid eye disease, with our differentials of left orbital tumor and also orbital inflammatory disease. So investigations, we divided into ocular investigation or systemic. Ocular investigation, so this patient, we perform a HES screen chart to assess for extraocular muscle movement function, whereby the left eye is grossly restricted in elevation and abduction, with right eye overaction in corresponding directions. We also perform a Jerome screen, which is to assess the visual field, whereby the patient seems to have an intact visual field, no restrictions, and no enlarged blind spot. Other investigations to ascertain thyroid eye disease include thyroid function test, whereby there was elevated free T4, 19.9, and also low thyroid stimulating hormone, less than 0.01. We also wish to exclude other signs of infection before starting steroid treatment, and also to monitor steroid-induced side effects. The FBC, RPA, LFT were normal with elevated HbA1c 10%. ECG showed sinus rhythm, no atrial fibrillation, no ischemic changes. Chest X-ray was normal with normal urine FEME. So we performed a contrasted MRI brain and orbit upon last year, October. We showed bulking and also enhancing left eye extraocular muscles, predominantly the inferior rectus and also the medial rectus. So this shows the medial rectus, but in thyroid eye disease, there will be sparing of the myotendinous junction. So it looks like a Coca-Cola bottle, and this one we call it as the Coca-Cola bottle sign, okay, with proptosis, if you compare to the other eye. Our final diagnosis is moderate to severe and active grace orbitopathy with CAS score of 4 out of 7 with biochemical hypothyroidism. Our principles of acute management include general recommendations, whereby we should refer to a thyroid eye clinic, refer to the oculoplastic team, stop smoking. The patient is not a smoker. Why? Because the patient will not be very responsive to treatment if the patient is on smoking. And we treat the patient thyroid dysfunction with anti-thyroid hormones, and we refer to endocrine team, and to avoid iatrogenic hypothyroidism as well. Ophthalmology management-wise, we started the patient on intravenous methylprednisolone 500 milligrams per week for 6 weeks, and also oral mycophenolate sodium 720 milligrams per day for 6 weeks as well. And we monitored in 6-week time, and the patient showed partial response. So we continued with a lower dosage of intravenous MTP 250 milligrams per week for 6 weeks, followed by mycophenolate sodium. During the high-dose steroids, we also prescribed the patient with proton pump inhibitors to prevent gastritis. So this was taken from the Google Guidelines 2021. So this is what we have done until this point. Okay, so regarding the patient's progress, upon the assessment of the 5th dose of IV methylprednisolone, during the 2nd cycle, the patient already showed signs of improvement. Vital eye vision and optic nerve function seems to be intact and good, with improvement of the staring gaze and also in EOM movement, as you can see. Okay. Then principles of long-term management-wise, if let's say the patient's thyroid eye disease becomes inactive later on, then we can consider rehabilitative surgery as needed, such as orbital decompression to reduce the proptosis, squint surgery to realign the eyes, and also lid surgery to address the lid-height asymmetry. Thank you.
Okay, thank you very much to Dr. Wai for a very clear and good case presentation. Next, I would like to invite Dr. Othmaliza Othman, our head of department, to present on the clinical assessment and also management of TED.
Assalamualaikum warahmatullahi wabarakatuh, and a very good morning to everyone, to all the professors, lecturers, fellow trainees, and as well as medical students. So I'm going to talk about the basic clinical assessment and management of thyroid eye disease. So we co-manage this case together with the endocrinologists, radiologists, right? And it takes everybody effort to make sure that he are able to having a good quality of life. So actually, having thyroid disease is very disfigurement condition. Actually, especially if you are dealing with young patient, because people will perceive them of angry person, because has this retraction and everything, and it's very disheartening, because they being perceived as somebody who is very menacing, right? So yeah, so that's one of the things that we need to look at, the aspect of this patient. So clinical assessment of this patient, basically looking into the history, physical examination and investigation. So clinical, just based on the ocular symptoms, you're looking into for blurring of vision, in particularly central scotomas, right? Because that's what would be the first thing that would come if you have the compressive optic neuropathy. Double vision, as illustrated in our patient, foreign body sensation, that is the most common complication of thyroid disease. It's actually having dry eyes, because you notice that the eyelid retracted. So sometimes they might, and having proptose, they might develop this exposure keratopathy, all right? So, and deep boring pain. So there's another question that you want to ask, okay? Whether this is actually at rest or upon movement, right? So medical history is mandatory. We need to look into the endocrine history. So this will be covered by our endocrinologist. Social history and habits, in particularly smoking. That is very important things to ask in our patient, yeah, because smokes makes worsen the condition. Not to forget about the depressive symptoms, okay? As I mentioned earlier on, this very disfigurement condition, patient usually they don't want to face the society. They felt very depressed because basically when you look at their previous IC photos and what they have now is so much different. So they don't feel that the face belong to them anymore, right? So when you look at the ocular symptom, just usually something like onset and a duration of less than 3 months. So unable to look at the blurring of vision, having double vision, scary eye, looking eye, and of course, pain in the boring, deep pain, boring pain, right? So depressive is another thing, all right? So physical examination, concentrating onto the ocular findings, okay? So I'm dividing this into 5, right? lid signs, facial signs, extraocular muscle signs, pupillary signs, and other signs. Okay, so this actually for the trainees are quite important for exam. So these are the things that we expect them to know, right? For the lid sign, so we have this Dalrymple sign. Dalrymple sign is actually patient have this lid retraction. It can be upper, it can be lower, or it can be either one of them. So it can be either in these three conditions. So what is the difference between the Kocher sign? It's actually worsening lid retraction. So when you saw patient with this lid retraction, with Dalrymple sign, you ask them to look far and fix onto an object. And you notice that there'll be worsening of lid retraction. Then there'll be Kocher sign. So Vigorok sign, this one patient at this sign, eyelid fullness, right? And von Graffe sign when there is lid lag upon down gaze. So this is basically the lid sign. Okay, right. Facial sign. So we have this tail wag sign, incomplete and infrequent blinking. Sorry for the some error there, right? So we blinks all the time. So that's one of the reasons that they got dry eyes, because the distribution of the tears is not well uniform onto the surface of the ocular surface, right? So if you less blink, you get more dry eyes. So that you notice that incomplete and infrequent blinking. Geoffroy sign, absence of forehead crease upon up gaze. So you notice if you look up, you have this crease there, but for this patient, they don't have it. And her Torch sign, basically loss of lateral third of the eyebrow. So extraocular muscles, we have valid sign, restriction of extraocular movement, and mobile signs, there's inability to converge, right? So they can't converge during accommodation, okay? And pupillary sign, others like Cohen sign, jerky pupillary light constriction to light, Lowy sign, midriasis upon stimulation of lower concentrated adrenaline. That means the pupil dilatation are more sensitive, right? And knee sign, unequal pupillary dilation in the dim condition. So other sign, this is quite common. I'm sure my trainees know about this, but actually there's a name for it. So Goldheiser sign, so bulbar conjunctiva injection, and then there will be conjunctival chemosis, the usual one, then caruncle edema, and Saltler sign, right? Increased IOP upon gaze. So it is something that when we check the IOP, we check at primary gaze, all right? And then we check again at up gaze, right? So there'll be changes, all right? If it's higher than 3 or 4, then it is significant and you have the Saltler sign. And then obviously proptosis is the next thing that you need to check. Okay. Right, investigation-wise, so we have blood investigation. This will be elaborated further by our endocrinologists. Specific ocular investigation and imaging by the radiologists, okay, by the radiology department and then elaborate further from our radiologists. So specific ocular investigation. So we do have visual field tests, like for example, Jerem, Humphrey visual field, color vision, Ishihara test, 100 hue M, optical coherent tomography for the retinal nerve fiber layer. So specifically, when we perform Humphrey visual field, sometimes you notice that patient has no complaint of field defect or blurring of vision. So we actually can predict whether they have early signs of compressive retinopathy by performing Humphrey visual field, blue on yellow perimetry. So if they have early changes, right? So we sort of like can predict the outcome of the case. So if you detect this in this condition, so you might be a bit more aggressive in terms of treating the patient, yeah, because you don't want them to succumb into optic neuropathy, and it will cause a lot of problem as well. So color vision test, Ishihara test, simple, easy to use, but however cannot quantify the severity or detect any blue-yellow deficiency. So first Mansell 100U test, sensitive to change. Ardent color vision is actually a computerized test, right? So this is one of the tests that is able to detect blue-yellow deficient among the dawn, which is this thyroid optic neuropathy. Okay, OCT. So what is the role of OCT? So if it's in my case, if patient meant for compressive orbital decompression surgeries, I will ask request for this. right? Because it's actually prognostic factor prior to this thyroid optic nerve decompression surgery. And also, we need to perform this as a baseline for secondary glaucoma, right? Patient usually would come later with secondary glaucoma if the orbit cavity are too congested with an inflamed and ongoing hypertrophy of the orbital fat as well as extraocular muscles. Yeah. So yeah. Now we look into the classification. All right. So what is the current assessment? Okay. So we in thyroid eye disease we always look into the activity and the severity. All right. So the activity is actually impression of the degree which the body reacts to the autoantigen. So whether it's active or non-active. All right. And severity because activity would signify whether you need to start your steroid or not. Okay, severity is actually physical consequences of activity that persist despite the control of activity. So for severity, it's actually determine how much you want to give, right? And whether you need to couple with other second line agent or not, right? And whether you need to perform surgery for this patient. Okay, so we have the most common thing that we do or use is actually CAS and UGOGO. But we do have others, but I think just to highlight onto the basic part of it. So we look into the clinical activity score. So Dr. Wai have mentioned that this patient has CAS more than 3. So initial CAS scoring, that means the first time patient see you, right? As an eye doctor, we score them this item out of 7. Whether patient has spontaneous orbital pain, any pain on eye movement, eyelid swelling, patient has it, eyelid erythema, any redness, any conjunctival redness, okay, any chemosis. So conjunctival redness and chemosis is 2 different things that you need to assess, right? And inflammation of the caruncle or pleca. For the subsequent visit, second and above, so usually we follow them up after 1 to 3 months, all right? So we add on more things to assess, okay? So whether we measure any difference from the previous baseline exophthalmometer, that means how much the proptose eye, right? Whether it's increased more than 2 millimeter, right? Decrease in eye movement at least more than 8 degrees, or decrease in visual acuity up to one Snellen line. So that means it worsened by 1 Snellen line. Say for example, patient was 6.6 vision, that means perfect vision upon the first visit, and then the second visit they got 6.9. So that means down by 1 line is considered additional 1 mark for the CAS, right? So you go looking into the severity, right? Mild, moderate, and side-threatening thyroid eye disease. So these are the characteristics that comes under this into the stage, right? So management, right, based on, as I mentioned earlier on, is based on the activity and severity. So that's a very important aspect that we need to have a look at it. So each follow-up, we need to see the activity and the severity. So we look at the mild GO, all right, graph of the orbitopathy. So local treatment, that is the standard for everyone with thyroid eye disease. Artificial tears, right, ophthalmic gel, all right. Systemic adjunct therapy for active GO, but mind you, patient needs to be in a euthyroid condition. So not in hyper or not in hypothyroid, so you make things, because it may make things worse, all right. We need, this is very important, right? Refrain from smoking, treat the this thyroid condition, avoid iatrogenic hypothyroidism. So we're talking about radiation, to reduce the hyperthyroid, right? Refer to a thyroid eye clinic, right? If there is a risk factor, and search for the dry eye symptoms, okay? Right, for the moderate severe, like our patient here, so patient has this flow, okay? Right, we have to add on mycophenolate, because mycophenolate is a cytostatic drugs that's affecting onto the cell B and T cells, right? So whether the patient has respond or partial respond, this is the algorithm accordingly, right? So general recommendation will be the same all throughout the stages of the thyroid eye disease. Okay, how about side threatening? All right, we can't really go into surgery just simply like that. We still need to control the inflammatory condition. So we still need to subject patient to the steroid treatment given, and then we evaluate the condition within 1 week, all right, whether the patient responded well to the treatment, then we proceed with the steroid. Hopefully they will get better and control the inflammation very well. Because if you do surgery with an inflamed eye, there's also risk of bleeding, because this has a very inflamed orbit, right? So you're dealing with orbital fat with lots of vessels inside there, right? So, but if there is need to do, then one need to go in and do. So especially if there are no response at all to the treatment, steroid treatment given, so we need to perform an urgent orbital decompression surgery, and where that's where our radiology is important to come in. That's because we need to plan the surgery plan of surgery accordingly. All right. So I think that's this is my reference. Any question can be asked during the Q&A session. Thank you very much.
Okay, thank you so much, Dr. Othmaliza. That was a very clear presentation on clinical assessment as well as management of TED, especially from the ophthalmology part. However, our job doesn't just end there. We can't just treat the eye without treating the patient as a whole. So managing the thyroid dysfunction and also managing the diabetes mellitus state of this patient is actually of a very important aspect of it. So without further ado, I would like to invite Dr. Mahrunissa to actually give us a talk on TED in terms of the endocrinology part.
Hello, Assalamualaikum, and very good morning to consultants, specialists, medical officers, students and everyone. My name is Mahrunissa binti Mahadi, and I'll be representing endocrine unit for today's CPC. As our today's topic will be on thyroid eye disease, or interchangeably known as grave orbitopathy. So I'll be explaining more on the approach and also management by internal medicine physician and also endocrinologists. So moving on, this case were already elucidated by Dr. Wai just now. A bit of summary, this is a 45-year-old gentleman with A1C of 10% and on combination therapy and also a good lifestyle modification. His A1C went down to 6.5% with underlying grave disease since 2024. No symptoms of hyperthyroidism, but there's a left eye thyroid eye disease whereby the CAS score was 4/7 and it's moderate to severe grave ophthalmopathy. So let us move forward to the thyroid function test. As you can see, the thyroid function test showed a suppressed thyrotropin with less than 0.01 and coupled with a slightly elevated, which is 1 times of upper limit of the free thyroxine, 19.77. So from the get-go, from initial presentation, he was seen and was started on tablet carbimazole, 20 milligram daily, and was seen 1 month after by an endocrinologist, and the carbimazole were reduced to 10 milligram daily. And as you can see, upon further follow-up, the thyroid function test had already normalized and he's currently euthyroid. So a bit of introduction on thyroid eye disease. The prevalence of thyroid eye disease among patients with grave disease is 38 to 44%, and in Malaysia itself, the prevalence is 34.7%. And as grave disease is an autoimmune disease, it usually involves bilateral eye. However, in cases whereby, such as in our case, it's involving only unilateral of the eye, the group of patients would be much older, involving frequently men, and it tended to have more severe presentation. As were mentioned previously by the other panelists, the state of hyperthyroidism and also hypothyroid itself will negatively affect the cause of thyroid eye disease, and it's very crucial for us to restore euthyroid state as early as possible before the patient went into fibrotic or quiescent phase of the thyroid eye disease. So let me direct you towards the diagram on the hypothalamic pituitary thyroid axis. As we all know, the thyroid gland will produce free T4 and also T3. The T4 will subsequently be converted to T3 over the peripheral tissue or target tissue, And this target tissue includes your heart, which in excess will cause cardiomyopathy, liver will cause hepatocellular injury or transaminitis, which is not unusual for patient with thyrotoxicosis to have hepatotoxicity. In excess, it will cause osteoporosis over the bone and also agitation in patient, especially in patient with thyroid storm. Production of T4 and T3 will subsequently inhibit the production of TSH by the P23 and also the thyrotropin releasing hormone from the hypothalamus. And this is why in patient with hyperthyroid, you will have suppressed or low TSH coupled with either elevated or normal free thyroid hormone. As you can see in our patient, there is no TSH receptor antibody sent. However, a clinical feature, which is an extrathyroidal manifestation such as orbitopathy, dermopathy, thyroid acropathy, coupled with suppressed TSH and also elevated T4 or T3, is already suggestive or good enough to say the patient is grave disease, 85%. If you have uncertainty, you can do a TSH receptor antibody, and it's very beneficial to do it if you have the facility to do it, and the sensitivity is up to 98% and specificity is 99% for grave disease. A bit on grave disease is an autoimmune disease whereby this is due to autoantibody towards TSH receptor, and this overstimulation and excess and continuous stimulation of the thyroid hormone will further cause an enlargement of the thyroid cell and cause goiter. That is why a patient with grave disease usually will present with diffuse goiter. So these are the treatment modality which we will usually offer for patient. How we decide? It depends on your discussion with your patient. And usually we will opt for the least complicated treatment modality, which with anti-thyroid drug, the failure rate is up to 50%, but the complication is 12% only. Compared to RAI, the failure rate is 7%, but the complication is 6%, and thyroidectomy, although is very low failure rate, less than 1%, but the complication mounted up to 24%. So usually we'll start patient with anti-thyroid drugs, and depending on whether the patient is pregnant, whether first trimester, second trimester, or the patient is compliant or non-compliant with complication, so you will decide on the treatment modality. So starting with anti-thyroid drug, usually the choices will be thionamide, include metimazole or carbimazole. The carbimazole is usually easily prescribed and less side effect compared to metimazole, and this is inactive form of the metimazole. As compared to thionamide and also propylthiouracil, usually you will choose propylthiouracil in patient who is pregnant at first trimester, in patient with thyroid storm, which you easily control or easily manage the thyroid storm, and also patient who have issue or adverse event with metimazole and carbimazole and cannot tolerate this thionamide and refuse for radioiodine therapy. So usually we will continue anti-thyroid drug for 18 to 24 months, but if there is failure to achieve euthyroid state or fluctuation or relapse, then only we will offer the patient for definitive treatment, which is RAI or thyroidectomy. However, nowadays, it is also a good option to offer patient a low thyroid medication, continuation, lifelong 5 to 10 milligram limitlessly. So this would be the table form of all the treatment modalities that I've mentioned just now. And as you can see, RAI is not a good option as it will eventually cause exacerbation and worsening of grave ophthalmopathy. So this table is adapted from the Journal of Clinical Endocrinology 2020, and as you can see, the management of grave disease, if a patient have a low TSH coupled with elevated T4 or T3, this patient has overt hyperthyroidism. If you have the access to TSH receptor antibody or TRAP, then if it's positive, then this patient have grave hyperthyroidism. But if you don't have it, but the patient has already extrathyroid manifestation or diffuse goiter, then this patient also have grave hyperthyroid. So the first management would be metamazole or thionamide group. And after 18 months, if there's no relapse or recurrence, then they may be continued with low dose ATD. So the risk factor for thyroid eye disease in this gentleman would be the non-modifiable one would be being male himself. And the non-modifiable one would be the cigarette smoking, thyroid dysfunction. So our management would be tailored toward this risk factor. That is why from Dr. Wai and also Dr. Othmaliza, they mentioned that a cessation or advice to stop smoking from the get-go itself is very important and need to maintain euthyroid state at every time. So apart from that, characteristic of high-risk thyroid eye disease also include unstable thyroid function and also diabetes mellitus, whereby that is why we needed to control the diabetic in this patient, aside from the treatment which will include pulsing steroid. So approach-wise, first and foremost, get your diagnosis right, manage the grave disease, maintain euthyroid state as early as possible before the patient goes into the quiescent or the fibrotic state of the thyroid eye disease. Screen for thyroid eye disease at every visit, as thyroid eye disease can occur up to 18 months of the grave disease diagnosis and vice versa, and prevent the progression of thyroid eye disease. So stop smoking, and I think Dr. Othmaliza already mentioned the management of mild thyroid eye disease in lung just now, and also early referral to specialist clinic if indicated. So is RI contraindicated in thyroid eye disease? The answer would be depending on the activity and also the severity of the thyroid eye disease. So usually anti-thyroid drug would be the get to go for this kind of patient. However, in patient with significant but no in the patient with presence of active thyroid eye, mild and inactive and mild, then you can give a low dose of prednisolone prophylaxis for a certain period of time before subjecting the patient to RAI. So I think that is all from me. Thank you.
Thank you so much, Dr. Mahrunissa. That was a very clear presentation. And then after looking at the blood investigation as well as options of management on the endocrine view, now let us look at what is imaging findings that you usually see in thyroid eye disease as well.
Okay, good morning, everyone. Good morning, professors, doctors, doctors to be, and our supporting staff colleague. So I'm Dr. Leong from Radiology Department. So I'll be sharing the imaging findings for this patient. So the only brain scan that we have is actually a MRI brain and orbit done last year, October. So this is a T1 sequence of the MRI brain in an axial cut. So if we draw a line across this area, so this is the zygoma bone, okay? So this is what we call the interzygomatic line. So from here, we can gauge whether the eyeballs are proptose. So there are certain measurements that we can refer to. So when we look at the line and we draw the vertical line across it to the most posterior part of the globe, generally the range given is about 1 cm plus minus 1.7 mm. So usually we just take about 1 centimeter. So if this is less than 1 centimeter, then we can conclude that the patient is having proptosis. There's another measurement that we can refer to, which is anterior to the interzygomatic line. The given range is less than 23, but usually I will just use this one. So if we look at both eyeballs, the one on the left is about 5 mm, okay, compared to the right side, which is 8.2, which is still within the standard deviation range, but imaging-wise, it's not so much into diagnosing a thyroid eye disease, but it's more like to exclude other things that we cannot assess beyond the eyeballs. Okay, so clinically, there's already proptosis. Yeah, more on the left side. So how this interzygomatic line is drawn, and to be reliable, the scan phase has to be acquired in this orbitomeatal line. So this is our meatus, okay, and this is the eye level. So if you draw a line, and the scan phase has to be in that plane. So this is the orbitomeatal line. So usually the radiographer will acquire the scan using what we call a scanogram, which is something that we can plan how we want to draw the scan. The scan can be done like this, or even like this. Yeah. So this is the orbitomeatal line, and from this plane, this is where you draw your interzygomatic line. So if I draw this, I try to do it manually by myself. Try to realign it. So you can see that the measurement is more or less the same. Yeah, there's some difference there. Inter-operator difference, so about 4.5. It is still way low than the standard range. So MRI brain, as you know, we have so many sequences. So the aim of these sequences is to let us see more things, get more information, and to rule out other conditions. So for example, like this slice, okay? So this is a T2 fat suppressed sequence. As you can see that the fat on the scalp area are all hypo-intense, so they are being suppressed. And the fluid in the CSF are bright, okay? So this is the superior ophthalmic vein. So this is one of the things that I will probably first look at when I look at any brain scans, okay? Because when you are suspecting anything over the cavernous sinus, thrombosis, any tumor infiltrating there, any inflammatory condition in the cavernous sinus, the first thing first that will respond is usually the SOV, because your SOV will drain into your cavernous sinus. So if that part is occluded, obstructed, usually this will be dilated, okay? But not all dilated SOVs are pathological, okay? So this is the first thing I look at. So at least, okay, shouldn't be anything down there, okay? So this is being taken at this slice, okay? I just show you the corresponding coronal plane to visualize where is this cut is being taken. So next, when we go a bit lower, so this will be the cavernous sinus, and this is a normal shape of the cavernous sinus. It should appear concave, and if the border is bulging, convex, then you must be you must try to look into the cavernous sinus and see is there anything inside that can cause that. So this is the usual shape. And on T2, usually you will see very nice ICA within the cavernous sinus. This is the cavernous segment of the ICA. So this is what we describe as the flow voids of the artery, because the flow in the artery is very fast, so it causes the signal to drop. That's why you see this is the basilar artery. This is the normal flow void. So we do not need contrast, but we actually can tell the patency of the artery. Okay, so this is rather clean. So just from one single image, we can tell that the cavernous sinus should be normal. And when we look in front, so this is around the orbital apex area, and the superior orbital fissure will be somewhere here, and we don't see any lesions around this area. So the orbital apex epicus were also clean. So this is acquired at the mid-orbit level. Okay, so coming back to this patient, this will be the lateral rectus, this will be the medial rectus. So in this sequence, you can see that the fats are all being suppressed. So this sequence is very useful, where almost all pathology in our body will cause an increase in water intake. That is why our MRI is using the hydrogen as our main substance in MRI. So we detect water. Okay, so when the fat is being suppressed, any high signal that you see, it means there's a presence of water, i.e. edema. So we can see that the lateral rectus and the medial rectus, they are bulky. And we also see that, as pointed by Dr. Wai earlier, the myotendinous junction is rather sparse. They are not involved. They are not as thick as the muscle belly here. And we also see there's some areas of inflammation here if you compare to the other side. Okay, there's increased water uptake at this area. Okay, so if we draw a line at the mid-orbit, the cross-sectional region, you can appreciate that the inferior rectus muscle and the medial rectus muscle, they are bulky. And I would say that the inferior rectus is even larger than the medial. So if in thyroid eye disease, classically, the involvement follows a certain rule, which there will be involvement of the inferior rectus muscle followed by the medial. So the mnemonic that I'm sure everyone has heard before will be I'm slow. So I and M are usually being involved. Subsequently, the superior rectus and the lateral rectus and the oblique later. So you can see that actually on the right side, it is relatively normal. The one being involved is on the left. And we have this index that we don't usually report it, but we can do some objective measurement if needed. So this Barrett's index is there are two ways of measuring this. One is what we call the vertical index. Another one is the horizontal index, where basically it is a very simple calculation. You want to know how much space you have in the for the optic nerve compared to the space occupied by the rectus muscle. So for this patient, if you calculate the vertical index, it is 57.7%. And for the horizontal index, it is 65.9. So this index is used to gauge the risk of patient developing into optic neuropathy. So if the number is more than 60%, then the risk of patient developing into this thyroid optic neuropathy is higher. So what are the differentials we are dealing with? So I've pointed out earlier that you need to look at the cavernous sinus, orbital apex for possibility of all these differential diagnoses. But in our usual practice, the thing that we want to exclude is orbital pseudotumor. So the image on your left, so this is an example of how the myotendinous junction is being involved in orbital pseudotumor compared to a thyroid eye disease. And as Dr. Wai has shared earlier, the description is as if like a Coca-Cola bottle. So the myotendinous junction is thinner compared to the muscle belly. So this is like a summary between these two commonest conditions that we see, thyroid eye disease and orbital pseudotumor. So if we look at our patient's presentation clinically is bilateral, but imaging-wise is unilateral. You can see that on the right side, the extraocular muscles, they are not involved. So thyroid eye disease, 90% are bilateral, but can be unilateral as well. So 1 point for our patient here. This is based on imaging, yeah. So onset, gradual onset. Pain, usually painless, but I think our patient described a bit of pain also, right? Yeah. So involvement of the extraocular muscle. So we have involvement of the inferior rectus and also medial rectus. So in orbital pseudotumor, they do not follow any rules, but usually the one being involved is the lateral rectus muscle. And myotendinous junction involvement. So in our case, this patient, it was not involved, but this is not actually a hard and fast rule because in acute presentation, it is reported that some of the myotendinous junction can be involved as well. So extent of involvement, lastly, if there's very frank infiltrative features, you have to think of orbital pseudotumor. So all in all, our patient clinically is having thyroid eye features with hypothyroidism, and radiologically it favors a thyroid eye disease more than orbital pseudotumor. So the final imaging diagnosis is thyroid eye disease with risk of this thyroid optic neuropathy. And orbital pseudotumor remains a differential diagnosis. Right, thank you.
Thank you so much, Dr. Leong. Okay, so finally, I am here to just wrap up. Okay, so let's close in and summarize a little bit about learning of our case today on thyroid eye disease. I hope the patient is the one with bulging eyes, but not us having this giddiness in our eyes and are unsure of what to do. So after the elaboration and elucidation by all our good panelists and speakers today, I hope all of us have actually learned something. So this is for you. Everyone has learned something today. This is your badge, so you need to take it home and then also remember all the points that were supposed to be learned, as well as also read up on things that you're not sure. Okay, so let me just run through again and summarize one more time about our patient. So this is Madam A, Mr. A. He's a middle-aged gentleman, but you can see he's still very young. He's still working. He is still functioning in society. Okay, so having problems, he doesn't have blurring of vision, but he has this displacement of his eyeball and proptosis. Number one, it's disfiguring, but number two, it's also very disturbing to have diplopia. So we might not really understand what diplopia looks like, but if we actually have diplopia every day in everything that we do, if it's constant, it can be actually very stressful. You cannot work, you cannot read. Medical students, I'm sure you know, if you want to see your phone, you cannot read your words properly, you cannot read what you're supposed to be studying, you cannot really write properly, and some people need to drive a lot, and then it'll be dangerous to their health, and then after that you have family members that you want to see, you cannot really see them clearly. So even though sometimes they come in and tell you they got blurring of vision, we check their visual acuity. It's 6/6, it's okay. But that doesn't mean that patient does not experience bad symptoms. Actually, they are having a very distressful life, okay? So they cannot see everything very well. And I think one thing that we didn't really elucidate later, just now, some of you might be wondering, why is the orbit involved in thyroid eye disease? So I think maybe that's a point that we should have discussed a little bit earlier. I forgot to mention that. But thyroid eye disease is not just a thyroid problem, because the thyroid circulating autoantibodies are in our system, and the orbital fibroblasts, which means that the tissue in our orbit actually shares similar receptors as the TSH receptor. Okay, that's why the autoantibodies go there and attack it. When it's attacked, the fibroblasts will then proliferate. That's why you get all the swelling in your eye, your muscle swelling, your fat proliferation, and then your imbibition of water due to your glycosaminoglycans. So that is the pathophysiology of why the thyroid eye disease actually happens. Okay, so now it's not just due to your hyperthyroidism. Hyperthyroidism does cause things like lid retraction because of the sympathetic overdrive, but the orbital proptosis part, the muscle part, the increase in the volume part, that is all due to the autoantibodies that actually attack in the orbital fibroblast region. Okay, so when it is attacked, it also shows signs of activity. Okay, the activity that we saw just now, mainly all your eyelid swelling, your eyelid redness, your conjunctival swelling, which is known as chemosis, your conjunctival redness, your caruncle redness and edema. All these things are actually inflammation. So these are the 5 cardinal signs of inflammation that I'm sure all, even from the medical student level, you should know, which is your calor. So you feel that is actually increase in warmth. Okay, that's calor. Rubor is redness. Tumor is the swelling, whether it is swelling itself due to the inflammation or the proptosis itself. All these are also swelling. Pain. Patient felt a little bit of pain, especially when he was looking up gaze. Okay, and loss of function, functionalacia. Also, maybe because EOM is also slightly restricted in this patient. When it's very swollen, sometimes the function of the organ itself might be affected lah. So he did exhibit actually a lot of inflammation in the eye. Okay, that's why when we look at his clinical activity score, it was quite high and significant. Okay, so aside from that, what did he have? He had double vision, but we also definitely need to check. Remember, in our list, we have mild, moderate to severe active, as well as sight threatening. So we need to see whether there is this thyroid optic neuropathy or not. And how do we do that? Is by checking your optic nerve functions, which was already elucidated by Dr. Wai, but those include visual acuity, RAPD, color vision, visual field, and etc. Okay? So, as a normal patient comes to your clinic, first of all, of course, we already heard about all the symptoms, his main symptoms being his diplopia, as well as some pain and also restricted EOM. Okay, we also assess the patient looking at all the clinical signs that he has. Okay, clinically he was euthyroid, no goiter, but when we look at his orbit, there was all the signs that we actually seen earlier lah, including your eyelid redness, eyelid swelling, conjunctival redness. He also had some pain on up gaze. Otherwise, it was pretty okay. Visual acuity was normal, no other optic dysfunction. Okay, so then we need to come to a few differentials. Top on the list, we would give him the winner would probably be thyroid eye disease, but we do need to also exclude the other differentials, including orbital inflammatory disease and orbital tumors. Okay, so then we did some investigations. Ocular we already seen earlier, and then biochemistry wise we also see again. So free T4 is high, TSH is low. Already mentioned why, because of the negative feedback. HbA1c is also very important for this patient because we are going to give him steroids. And one of the side effects of steroids is actually it will make your sugar haywire. It will increase your sugar levels. That's why sometimes it's very important to actually assess them, especially during their visits, whether their blood pressure is affected, whether their sugar is affected or not. Okay. And then we also prescribe patient with a PPI because one of the side effects of steroid is actually gastritis. In long term, sometimes we also give things like calcium and things like that to make sure that they don't get osteoporotic, depending on the patient. We also need to make sure that when we are giving some immunosuppression drugs, which is actually steroids are actually immunosuppressive, okay? So we also need to monitor and make sure that patient is not actually having any infection lah, okay? So white cell count is also another thing that we monitor. And then looking at the imaging that was very well already explained by Dr. Leong. So what we see here is mainly inflammation of the muscle with sparing of the tendons. So again, TED has like a Coca-Cola bottle sign, sparing of the tendons because this tendon area, the tendinous insertion is usually not affected. So the muscle belly is affected, okay? Whereas orbital inflammatory disease, usually the whole thing gets, sorry, you can't see my, oh, you can, okay. So the whole muscle gets affected, including the tendon itself that is in your orbital inflammatory disease, okay? So that's a good differentiation to at least know, okay? So after that is our job done, okay? We think it's TED, but we have not classified the severity yet, so we need to classify the severity. And this patient falls into this moderate to severe GO because he has more than 2 of the following, like he has lip retraction, moderate to severe soft tissue involvement, a bit of exophthalmos of more than 3, just now 18 and 21, and he also had constant diplopia. He falls into this category, but was not severe enough to fall into the sight-threatening category. He did not have DON, he did not have corneal breakdown. Means his cornea is not exposed until it gets a corneal ulcer, okay? But it was not mild enough to go into this category lah. So severity is then already determined. Then we need to see whether he had activity or not. So he had gaze-evoked orbital pain, eyelid swelling that was considered to be due to active GO, eyelid erythema, as well as conjunctival redness. So 1, 2, 3, 4, more than 3 is considered active. So therefore, we came to our final diagnosis, which is moderate to severe and active GO, and therefore started him on the first-line treatment. So it depends whether you want to go into this line or you want to go into this line. We decided to give him a second line, so we didn't need to give so much steroids. But do look at it, okay? You are getting 0.5 grams of intravenous MTP per week. What does that mean to the patient actually? It means that patient need to come, need to take blood, make sure that they are not having any infection. They need to go to our daycare, wait for you to attend to them, okay? And then after that, get their infusion, and then get cardiac monitoring sometimes, and then sometimes they need to wait for their blood results very, very long. The lab runs it very, very long. Then by the time they get their infusion, it'll be like 4 p.m., 5 p.m. Then sometimes they need to go and make payment. They need to go collect their medication. And it will be 1 whole day of treatment in the hospital. So you need to come every week for that. Not just for 6 weeks. If you're responding, continue again, come for another 6 weeks. Actually, it's not very easy for the patients lah. Okay? They already have these problems. They are working. They want it to be better, but it's not easy. So aside from being just a doctor who knows how to treat patients, always try to learn how to have a little bit of empathy as well. I'm not asking you to sympathize for the patient, but do try to understand how difficult the patients actually have it for them, okay? So yes, we did a very good job. Patient looks better. The proptosis is better. Doesn't look so disfigured anymore, but the diplopia is also better. But yeah, always try to remember that our mission is not complete. My mission today to deliver the CPC is complete, but the mission for treating this patient is not, okay? So do remember to treat our patients, and I think all of you have learned something new today, and I hope that you will take all these things back. If not only learning about the clinical assessment management of TED, or in the endocrinology part, or whether it's the radiological findings, I hope all of you can also learn how to be good doctors. Okay, so here you are, ready to save the day. Okay, thank you. Okay, now it will come to a time of session of Q&A. I think we have very good speakers with us here today, so do take the opportunity to ask, especially if you have anything that you have been always reading and very not sure about. Yes, Prof. Me. Okay.
In this case, is it? No. In thyroid, because there's, I think, in places or in countries whereby there is selenium deficient, they supplementation with selenium in patient with mild grave ophthalmopathy does give benefit, does improve the progression of thyroid disease. I think because of the involvement of the selenium within the progression and also the activity of the disease. But in our case, definitely selenium is not an option for him because he's already moderate to severe because of the severity of the disease. Yes, it's for mild only. Yes. Uh, yeah. This is a grave disease because of the activity of the because of the presence of autoantibody toward the TSH receptor, and then the carbimazole itself will also inhibit the activity of this the antibody itself. But like what Dr. Niki mentioned just now, the presence of grave ophthalmopathy itself is not just because of the hyperthyroid state only. So that's why in thyroid eye disease, especially moderate to severe, they will require immunosuppression also lah to inhibit the activity of the TSH receptor antibody also, the antibody itself.
Sorry, let me just repeat my question.
Okay, sorry, Prof. Sorry.
If Graves' disease, like no grave ophthalmopathy, just Graves' disease, why is immunosuppression not the first line? Because you've listed all the treatment, but like steroids is not the first line for Graves' disease, not ophthalmopathy.
Because the pathophysiology of Graves' disease itself, it involves the TSH receptor antibody. This carbimazole and also this anti-thyroid medication will also inhibit the activity of the TSH, this trap activity. That is why it's also enough for this patient to receive this antinomide or also PTU lah. So it's basically it's not a part of the thyroid. Regime of the treatment lah. Basically, Prof.
Yeah, I think that also when the autoantibodies go to the TSH receptor.
Sorry.
Okay.
Prof. Shari, I think Prof. Shari is here. Sorry, I don't have any voice. Maybe just to answer that. So, autoimmunity, not all autoimmune disease needs steroids. Only those autoimmune with inflammation. Okay, for example, Graves' disease doesn't involve any inflammation of the thyroid. If you have diabetes type 1, it is an autoimmune disease. It attacks the eyelid, pancreatic, but it doesn't have any inflammation. So no steroids. But Graves' ophthalmopathy, they definitely have inflammation. Okay.
Yeah. So I think Prof has mentioned that there's no inflammation due to that. Just mainly when it attacks the TSH receptor antibody, the thyroid becomes very hyperactive, and then the thyroxine is very high, T4 or T3. So we just need to deal with the side problems that is caused by that. Okay. All right. Any questions? Any other questions? Maybe my master students or medical students, we encourage you all to ask questions. Yes. Come. Any questions from your? Is it clear for you all? Do you all understand? Yes, okay. All right, master students. You are hungry for learning, right? No, okay. I guess if there are no more questions, I think the talks were very good. And I hope everyone has learned something today. Thank you for your attention and for your time. Okay, thank you.